So good evening, ladies and gentlemen. Again, thank you for being with us. This evening I'm reporting to you that today we have diagnosed through our Irish laboratories an additional 629 cases of COVID-19, and there have been an additional 95 notified cases diagnosed through the German contract that we've been telling you about in the last number of days, bringing the total number of cases now confirmed in Ireland to 13,271. That's 13271 cases in total. There have been an additional 43 deaths notified to us today, bringing the total number to 486. There has been an adjustment. One death has been denotified, so that's just if you're adding the numbers. Of those additional 43, 34 in the east, 4 in the west and 5 in the south. 22 are male, 21 are female. We've been notified that 27 of those 43 have an underlying medical condition, and the median age of those additional deaths is 84. Of the 486 deaths that we've had notified thus far, 298 of those, or 61%, occurred in a hospital environment. 44 of them occurred in an intensive care unit. That's 9%. The male-female breakdown is 283 males, 203 females. That's 58% to 42%. The median age of those deaths overall is 82. The mean age is 69, and the range of ages is from 23 to 105. And in 83% of cases, or 403, we've been notified of an underlying medical condition in association with those individual deaths. And I'd like to take this opportunity to express our condolences to the families and to the friends of each and every one of those individuals who have lost their lives over the course of our experience with this epidemic. In terms of intensive care, we've now seen 290 admissions, 156, again a slight drop, remaining in intensive care. That's 54% of the 290. 90 people have been discharged now. That's 31% from intensive care units. There have, as I've said, been 44 deaths in people who were admitted to intensive care, and that accounts for 15% of all intensive care unit admissions. 238 of those admissions to intensive care have an identified underlying condition notified to us, and the median age of all of those intensive care unit admissions is 60. In terms of the more detailed breakdown of cases notified to the HPSC up to and including midnight of Tuesday, the night before last, the total was 12,425 cases at that point, 45% of which were male, 55% female. Just over 2,2026 of those cases were hospitalised. That's 16.3%, a slight drop, you'll note. Admitted to intensive care were 284 of those cases. That's 2.3%. There were 480 deaths at that point, or 3.9%. 425 clusters were notified among those, accounting for 2,451 of the cases. And 25% of those cases were healthcare workers. And overall, in relation to all of those incident cases, the median age was 48%. In terms of outbreaks in residential settings and in the community, there have now been notified through the HPSC and to us 254. That's an increase of 4 from yesterday, and those 4 were nursing homes. The total now of nursing home clusters being identified is 163, and we've had reports of 302 deaths in total associated with the nursing homes, with community residential settings overall, 253 of which relate to nursing homes. And just one small additional piece of information, part of the Amárach research that we do twice a week, we have 28% of the population surveyed indicating that they are avoiding a GP, more than half of whom, 55%, are saying it's because they're afraid of picking up the infection. And again, taking the opportunity to encourage people to attend, to consult with their GP, to attend for health services when they otherwise would if they have concerns. It will be for the health service to ensure that people are protected from this infection. and we can give people assurance that the best possible measures will be taken by the healthcare system to try to ensure that people can be protected, and so they should continue to come forward to seek medical care when they believe they need it. I'm going to introduce again Professor Philip Nolan, who, as I've said before, will join us on a Thursday evening each week to share with you the latest information that we have from the modelling work that he and his team and very large team has been doing over the course of the week to help us to better understand where we might be going with this epidemic. Philip.
Thanks, Tony. So I'm going to take you through what we know or what we've observed about the epidemic since it began on the 29th of February, and then tell you a little bit about what our models are showing. It's complicated material, so it's going to take a little bit of time to work through it. My apologies in advance for that. I just want to say at the outset that models are very useful and very powerful, but just to alert you that, of course, the output of models depends upon the assumptions. And there are many assumptions in these models, two of the key ones being the proportion of people with COVID-19 who will be asymptomatic and therefore undetected. And they also depend on the data that we have to calibrate the model. And as the weeks go by, we're getting more and more data. And we have about 3,000 positive cases back from Germany now, which we're backdating into these models and recalibrating the models as we go along. And the second thing to say is that these models are useful to support decision making, but they're no substitute for good public health decision making and good clinical decision making. So we need to not read too much into them. They're very useful, but we shouldn't read too much into them. And because we're constantly getting new data and constantly recalibrating, you should be aware that when you see these models again in a week or two's time, they'll look a little bit different because we'll have got better data and better calibrations of the data. I don't think the fundamental message will change, but the actual numbers might look a little bit different. So let's start with what's been happening in terms of the epidemic. This is for those of you not familiar with it, a log linear plot, and we tend to show epidemics on these kinds of graphs because they show exponential growth as a straight line. But just to look at the y-axis, it's going from 1 to 10 to 100 to 1,000 very, very quickly. And therefore, rapid growth shows as a straight line, and you can see subtle changes in the growth rate of an epidemic on these plots. So this is the cumulative number of cases with those external tests done in Germany. Not all of them are back, but most of them are backdated. And you can see the slope of that line rising very sharply in the early days of the epidemic. And you've heard this before, when the epidemic was growing at about 33% per day. And now you'll see this, that's not flat, but it's very much less, that there's a really marked change in the growth rate of the number of cumulative cases. The same is true of hospitalizations. Hospitalizations are growing very slowly at this stage, and I'll show you a little bit more data on intensive care. This is the cumulative admissions to intensive care, the number of people who have ever been in intensive care in the country. But again, you'll see that the rate of growth in that parameter is now very slow. Sadly, as has been reported to you, the number of people dying continues to increase, but even in that parameter, the rate of growth of number of deaths is decreasing, and we'll be watching that number very closely over the week to come. So the first piece of information is that as modelers, one of the things that we need to do is look at all the data, not just test confirmed cases, but all the information that we have. And in each of those metrics, we're seeing very considerable slowing in the growth of the epidemic. Here's a plot that you've seen before. This is that growth rate figure that I mentioned. This is in cumulative cases. Each day, what was the percentage growth in the total number of cases compared with the preceding day, and we averaged that over 5 days. And the growth rate in cumulative cases has been very stable now for over a week at about 5%. And if we look at the number of new cases per day, now this is noisier. The number of new cases tends to go up and down a little bit for various reasons. So this is the number of new cases each day. How much has that increased compared with the preceding day? Some days it's going up, some days it's going down. Again, that's averaged over 5 days. And the takeaway message here is that since about the 3rd of April, the growth rate in new cases with those German tests backdated has been close to zero. So we're seeing very little growth in the epidemic in the community at this stage. Just I said I'd mention the number of people in intensive care. Again, that's the number of people reported by the HSE to be in intensive care, and that has been stable again since about the 3rd of April. We've been looking at 140 to 160 people in intensive care, and one might even imagine that's beginning to decline at this point. Finally then, sir, maybe just to the final indication that we have of the growth rate of the epidemic is this very famous reproduction number. We have 4 separate ways of estimating the reproduction number available to us at the moment. And as of yesterday, all 4 were showing the reproduction number somewhere between 0.7 and 1. And 1, of course, is that very important level that we need to get it below in order to be confident that we have controlled or suppressed the epidemic. This is a very complex presentation, but it is one of those approaches. This is a model developed by colleagues in Imperial College London, which we've adapted and allows us to compare the reproduction number across a number of European nations. And what it does is it looks at the number of cases that we've seen and the number of people that have died. It also, the model knows, if I can put it that way, when we've imposed different social distancing measures, when we closed schools and universities, when we closed pubs, restaurants and so on, and then on the 28th March, when we went into our current very restrictive social distancing measures. And the bands on the right-hand panel are showing you where the model thinks the reproduction number is. So on the very left, the green bands are the 50% confidence interval, the light green bands, 95% confidence interval. So as with all statistical things, it's not certain, but we're saying in the early stages of this epidemic, the reproduction number was somewhere between 2 and 4. Immediately after the early interventions, it looks like the reproduction number was somewhere between 1.5 and 3. And then the last panel shows the pretty high level of confidence in this model that the reproduction number is now below 1. So 2 messages there, an optimistic or hopeful message that we have controlled or suppressed disease, but an equally important message that the reproduction number was quite high before the measures of 28th of March were introduced. So if we're thinking about relaxing measures, even slightly, we need to be very careful we don't go back to that reproduction number of 1.5 to 3, and let me show you why. So with all of the caveats that surround models, here's what might have happened. So we're going to start with what an unmitigated epidemic might have looked like. This is what an unmitigated epidemic might have looked like. I'm reminding some of you, because I've shown you this before, that around this week, actually, we would have been looking at 120,000 or so infections in the community. That's using a reproduction number of 3.7. If we look at how the epidemic would have behaved if we had only succeeded in reducing the reproduction number to 2.7, let's call it a partially mitigated epidemic, we would have seen a very significant effect, but still a huge number of cases, around 70,000 cases at the peak of the epidemic out into the month of May. So we would have delayed it somewhat, reduced it somewhat, but nowhere near enough in order to make this manageable. Now, if I could just say, if the epidemic had continued with that reproduction number of 2.4, we would have been looking at 7,800 cases today, not closer to 700 cases. We would be looking at 800 people in ICU. By this day next week, we would be looking at 2,200 people requiring critical care, and we wouldn't be able to look after them. And even if we were, this day next week, we would be looking at a total of 1,700 deaths and 4,800 deaths by the end of the month. So this is a very serious situation which was prevented by the measures taken on the 28th of March. Even if we succeed in getting the reproduction number down to 1.2, we delay the epidemic greatly, well out into the August-September period. But even at that number, the peak number of cases there is close to 5,000. And that number of cases sustained over several weeks would be an enormous challenge for our healthcare system. So it's from this we get to the position that we need to suppress the disease. We need to keep it suppressed, and we need to keep that reproduction number at or very close to 1 in the long term. So that's the first model output, and you've seen much of that already. Where do we think we are now? We are hopeful that we're zooming in on just the month of May, really, with an expanded y-axis so we can see the detail. The red is the partially mitigated epidemic at reproduction number 2.4. Grey is what would have happened, what we predict would happen with a reproduction number of 1, and we're hopeful that we're somewhat below 1. We have some confidence that we're a little bit below 1, and this is the pattern we would expect. A peak of cases occurring around now, and we should be seeing a decline in cases into the coming weeks. When we look at the actual observations on top of that, the number of cases we're seeing, you see that in statistical terms, the number of cases is noisy. It changes a lot on day to day, but it's stable over time. That emphasizes that whatever our models might tell us, it's prudent and important to confirm what's actually happening in terms of the number of new cases seen, particularly with an enhanced testing regimen, the number of people attending hospital, the number of people requiring critical care. So again, it's a very prudent step to continue the current measures until we are absolutely certain that not only do models tell us they're working, but actual experience tells us they're working. So that's the first message. We think we're on the green line trajectory here, but we need more data to be certain that we are, because the data is variable. Let's just turn our attention, and you'll be relieved to hear the last slide that I'm about to show. Let's turn our attention to what might happen if measures were eased around the 5th of May. So we're looking at the most optimistic scenario, an R reproduction number of 0.8, that the number of cases will reduce towards the end of the month. And then imagine in early May, we relax the current measures for a period of 3 weeks, and then if we have to, we reimpose the current measures. Now, don't misinterpret me. I'm not saying that's what's going to happen. This is simply a scenario that we're modeling. There's the data. If the more relaxed measures also succeed in containing the disease, and R doesn't go above 1.1, the reproduction number just peeps above 1, we'll get a small increase in cases, and the reimposition of measures will suppress the disease again. If the reproduction number goes a little bit higher to 1.2, we get a slightly larger but manageable peak in cases, and a reimposition of measures will again suppress the disease. If the reproduction number goes up to 1.6, and imagine what that means. That means if one person gets infected, they infect one other person, but the second person infects 2 people. So every second person infects 2 people, and every second person infects 1. We see quite a significant peak in cases at that point, but again, reimpose strict measures and you regain control of the disease. If the reproduction number goes back above 2, back towards where we were with the kind of straightforward social distancing measures before the 28th of March, then we get a very sudden and almost certainly unmanageable spike on disease. Now, you clearly wouldn't leave the relaxed measures in place for 3 weeks and watch that happen, but it sends a very clear signal that whatever happens after the 5th of May has to be approached exceptionally carefully. We can manage a modest rise in cases if it's done slightly wrong, but we can't manage a huge rise in cases. So there are the outputs, and give us a very clear picture of where we are, I think, and the care that we need to take when we approach decisions in the run-up to the 5th of May about where we go next.
Thank you very much, Philip. So we're now happy to take any questions that you might have. David.
Thank you. So David Quinn, Sunday Times. Of the confirmed cases, do we know how many are in the nursing homes? That's question one.
Confirmed total number of cases?
Yeah. So what is it, over 13,000 confirmed cases? So do we know how many of those are in the nursing homes?
We've the breakdown of the number of deaths from nursing home settings, but the total number of cases, we don't have a breakdown on those from nursing homes, no.
Okay, so that's a big gap in the knowledge then, isn't it?
Well, there's active testing in nursing homes,
Yeah.
where there's surveillance carrying out in nursing homes. One of the complicating issues is some people from nursing homes are transferred to acute hospitals for care. So the surveillance traces them from their point of origin, which is in a nursing home setting. So.
Okay. And the second question is, so there's about there's slightly over 3,000 confirmed cases among healthcare workers. Do we know how many additional healthcare workers are self-isolating because of contact with a confirmed case?
We don't have data on we don't report on that. So.
What I might help you with, just in terms of the clusters, if you go back to the information that I shared, and this won't necessarily be, but if you take a cluster, we identified up to midnight on Tuesday night, I gave you this information, 425 clusters. There are now 254 in community residential settings, and they will be all of different sizes that have been notified. And those 425, bear in mind that some of those will include clusters that are not in community residential settings. Some may be in hospitals and some may be household clusters. They account for 2,500 cases between them. So the total portion that would be nursing homes would be a substantial number, but a substantially smaller number than that 2,500.
Okay. Okay. Thank you.
Right. Just the nursing home situation was described today as catastrophic in some terms. Are we currently failing the most vulnerable people in those nursing homes?
So Colin will wish to add to what I have to say, but we're seeing a different experience of this infection for sure in the general population than we're seeing in nursing homes and community residential settings. We've seen, through the efforts of society, a significant suppression of the infection. The information that we've given you this evening, the confirmation that it seems to be increasingly confident that we've suppressed the infection, that it's stopped growing in effect, and we're seeing that across a number of parameters. We want to continue to monitor that to confirm that that's the case. But as an objective, which was our primary objective, was, and I use these words on a number of occasions, to drive this infection from the community, we've made very, very significant progress in that. That's the first measure that we have to take to protect our vulnerable. If we don't have this infection, if we have this infection in the community, spreading in the way that it was, nobody's protected, particularly our vulnerable. So the first objective has to be to do that. The next objective then has to be to focus on those places that have a particular challenge. And so for the last number of weeks, we have been focused on the question of nursing homes. We know both from the data that was coming to us long before this infection came to Europe, and then with the increasing experience we have in terms of its European spread, from the advice that we have from the international organisations, WHO and ECDC, that this infection presents a particular risk, both in terms of the frequency of infection, and also for the impact of that infection for people who are older and belong to the vulnerable groups that we've identified, and we've been identified from the beginning. That's why some of the measures we've taken, not just in relation to nursing homes, but in relation to cocooning, are specifically about protecting those people who are most vulnerable. What we need to do now is to continue the focus with the measures that have been recommended by NEFIT, that the HSE is working to implement with the support of HICWA as regulator, to try to ensure that we can focus the work of the public health teams, the clinical teams that we know are involved with the nursing homes in trying to help those to limit the impact of this infection, and primarily to prevent the transmission of this infection in those settings. To add to that, our efforts to prevent this infection from getting to nursing homes and community residential settings that have yet to report clusters or that have not had an experience with this particular infection. So we need to continue with the implementation of those recommendations, and we think we need to expand some of our testing and focus our testing specifically on staff in those nursing home settings and maybe on patients in those nursing home settings as well, so that we actively seek the infection in those locations. so as to help to continue to inform the efforts that we're making. And we'll be doing that work over the course of the coming days as the laboratory capacity has increased, and we know that it has through the efforts of the HSE in recent days. So that will be the strategy, and it follows the perfectly appropriate strategy of, in the first instance, we need to control the community spread of this infection, and we think we've made very significant progress in that, and the data that we've shared with you this evening confirms that and confirms our assurance in relation to that. And we now need to focus, in line with the international advice, on where this infection is. So we'll be going after the infection in the nursing homes and community residential settings, as we've been doing in recent weeks, as aggressively as we possibly can.
Could I just add to that?
Colin.
There are a number of challenges in nursing home settings which are particularly difficult in the light of COVID-19. First is we know that the virus has a much greater morbidity and mortality among frailer older people. And the second thing we know from clinical experience is it presents differently in older people. Those classical symptoms we see in younger people, cough and temperature, are often absent in older people. For somebody, for example, who may be immobile or have advanced dementia or have other comorbidities, those core features that we see which are much more prevalent in younger people, namely a high temperature or cough, may be absent and may present either asymptomatically or in the context of a general going off or falls or a deterioration or not eating. And that presents a particular challenge in identifying cases early. What I could say is in terms of a response, there's been a very robust response by public health departments around the country, along with clinical teams. And I saw a really good example of this today, which I think deserves highlighting, in St Fintan's Hospital in Portlaoise, where there was an outbreak in a long-term facility for people in a mental health facility who've lived there in their home, so to speak, for many years. And the public health team, led by Abby Collins, over the entire of Easter bank holiday weekend, were there with the team from the acute hospital, who are up the road, working with the mental health team in, first of all, putting in those essential measures of cohorting, isolating, and also working with the clinical teams in identifying the best clinical care for each patient, which involved tailored care with the active instruction and involvement of Dr. John Compton and his team from Portlaoise Hospital, and also end-of-life palliative specialist care. And this, if you like, a combination of specialist nursing care from, if I could name one other person, Tracy Quigley, the ADON there in St Fintan's, with the local acute hospital, with public health, is the kind of combination we need to see in outbreaks, whether they're mental health facilities or nursing home. It's public health led, it involves testing and involves clinical care, and it's in a very vulnerable setting in people who present unusually, atypically, and sometimes silently, and presents particular challenges for clinicians and for public health in terms of how we address this.
Okay, but there seems to be a lot of reports of people who signed up for the On-Call, Ireland On-Call initiative, and saying that they didn't get calls, and and reports of a lack of staff to cover shifts in nursing homes. I mean, has that been a problem? Is there any numbers for the people who signed up for On-Call who did get deployed?
Yeah, I've seen such reports. There's large numbers of people who have signed up for On-Call, and of course we want to deploy them to the area of greatest need. A number of weeks ago, we were worried that our hospitals will become overrun on intensive care units, as we've heard now. Thankfully, that hasn't happened. The biggest challenge we have now is the management in a very highly vulnerable setting where the disease presents sometimes atypically. And it's important for people to understand that whether it's private or public facilities, there are existing clinical governance arrangements there. There are existing arrangements in our own facilities. For example, we have geriatricians who have active involvement in community hospitals. We have trained nurses in some care of the elderly facilities. In private nursing homes, there are GPs, either singly cover the whole nursing home, or groups of GPs or practice of GPs who provide the cover, who develop their own skills and knowledge in end-of-life care or care of frail or older people, and similarly with the nursing. So rather than replace or displace those, what we need to do is support. And as I said, that example I saw in Portlaoise earlier today was an example of the patients staying in their home, where they've been cared for sometimes for up to 20 years, supported by acute hospitals, supported by palliative care, and led by public health. And it's that kind of that kind of strategy, a combination of those disciplines, that will help nursing homes, not that by displacing their care, but by enhancing and supporting, that will help them through this particular pandemic crisis.
Thanks, Neil. George?
Just Colin, on the nursing home, I might as well, because you're just on it. Do you think in any case maybe the state should have taken over nursing homes in the same way that they took controls of private hospitals? Like the message seems to be, and successful and all as it has been, some people might interpret it that you were interested, number one, in the capacity of the healthcare system for obviously good reasons, but that the issue of the death of elder people came second. Like you were perfectly willing to do deals with the private hospitals, but not deals to take over for a short period of time the nursing homes. Just as a question, I wonder what would you say to that?
Well, George, first of all, my own profession is as a consultant geriatrician, so for my own training and strong belief, the idea that older people would be denied or given another form of care, whether it's acute care, hospital care, or even critical care, or end-of-life care, there should be no distinction. In terms, it is important in addressing this question to look at the scale that's involved here. There are over 500 nursing home facilities in Ireland. About 1/5 of those are HSE or public. The rest are private facilities where there's existing clinical governance, existing GP practices who support the care and guide the care, many of whom have received specialist training in end-of-life care or chronic disease care, in diabetes or heart disease or chronic lung disease. The idea that in the short time scale we would replace that and rebuild a form of care is just not tenable. What we must do is build on what we have. Clearly, if, as people say, if we were starting again and building a service for older people from scratch, it mightn't look the way it does now. Right now, we have to work with the people who are providing care. In most cases, providing very good care. And we have to give them the supports they need in terms of the scale of the problem they're facing, in terms of the number of older people who become unwell in sometimes atypical circumstances, and particularly in making sure that the appropriate clinical decision is made on an individual basis for each patient. If that involves transfer to acute hospital, that will happen, and it has happened. But as anyone who's had experience of parents or other people in nursing home settings, we know that what we prefer to do is provide care on site in their home where they get care from day to day, and that's what our aim to do is support existing care structures and enhance them to allow people to be cared for there and transferred if that's clinically appropriate.
Philip, could I ask you about your most interesting model? The reproduction rate of 0.7 to 1, do you consider it stable now?
Yes. So the patterns of the epidemic over the past week have been really quite stable. And the one exception to that was the number of new cases per day. And add in the backlog tests that went through Germany, and that becomes stable. So I think you could summarize it as most of the indicators of the behavior of this epidemic have been stable since around the 3rd of April. And that's an important takeaway.
Okay. I'm wondering, I know that these were projections and imaginations, like if you lift various restrictions, you could have changes of various kinds in your reproduction rate. I'm just wondering, with your knowledge of your model, what would it take to get the reproduction rate up to 2, which was unmanageable? Have you given an idea, or can you give us an idea of what would give us back to 2?
It's very easy to get the reproduction number to 2. This is an infectious virus, so the way to get it to that level is if people start to behave in ways which transmit the virus. So to turn the question on its head, we need to think about not so much specific activities that are types of activity. We need to think about how to go about the activities of living safely. So the important thing is to interrupt the pathway of transmission from person to person through distancing, hygiene, and in particular the control of droplets and particles from nose and mouth. So one of the difficulties with this virus is it's easy to transmit it. And it's for that reason that whatever changes that might occur after the 5th of May have to be very, very carefully thought through and very imaginatively thought through. Things that need to be done, how can they be done with a very low risk of transmitting the virus?
And in making that judgment, you're taking a risk because you couldn't predict, presumably, it's more a question than a statement, presumably you cannot predict the impact of, say, letting people back to school just off the top of my head, and only that. You have to wait and see, so you have to be ready to clamp it down again if it doesn't work. You're guessing.
Precisely that. These kinds of models are not going to tell you in detail how specific things like that work. These are population level models. And even that question, you take any given activity in society and it can be done a variety of different ways. So there's a subsidiary question about schools, for instance, about how might that actually be done. Bringing people into close contact where there's a lot of mixing between people who don't normally mix is a very high risk activity. So you can assess the risk, but that's more a public health question for the likes of people on the other end of this table than a modelling question for people like me.
It does come back, though, for Colin, for instance, and I'm sure Dr. Hulim will be very conscious of this. You need to put huge pressure on the HSE, surely, to up their act in terms of where the testing is right now. Because you can't do what is required, what Philip is saying, because we don't know what will happen with anything, but you need to be able to be sure where the outbreaks would be.
So we need to continue to work together, not just with the HSE, but the whole of government. Getting our testing and other elements of this has involved a huge amount of effort, not just by the HSE, but also supported at times by various actors across government who've had to help either in terms of supplementing our contact tracing capacity or helping with the effort to try and get reagent and the challenge we've had to overcome in relation to some of those things and some of the other challenges we now see, for example, the ENFR laboratory, but normally works in the agriculture sector. So this has been a whole of society effort to try and put us into this situation and obviously to support the HSE and what its core task is. What the HSE is being asked to do in this situation is way outside of the norm of testing or contact tracing or sampling or anything we've ever seen before. And so it's not a case of me putting pressure on the HSE. We do have to ramp up that testing capacity. You may be aware, George, that the WHO has produced new guidance this week around just the kinds of measures that need to be in place, and it is even more exacting in terms of its requirements than would have been the case in its previous advice. The turnaround times that we need to see in terms of being able to identify cases and report those back to the individuals who are infected, 24 hours is what it's identifying. That's going to be a significant challenge. It's going to put pressure on our testing capacity, on our sampling capacity, on our contact tracing capacity, and our capacity to both test and then follow up for 14 days each one of those contacts. But that's what we have to do. And we have to put those arrangements in place quickly, and we have to put those arrangements in place before we can contemplate changing the case definition which we've spoken about and making the case definition broader and more sensitive, because ultimately the objective of this, to bring us back to the point you're asking Philip about, is to give ourselves the maximum chance of detecting a case or cases that might arise from a change, particularly something we hadn't anticipated. So we can model and we can try to estimate what we think the impact of something will be, but as I've said before, we could be wrong. There isn't a rule book, there isn't a journal article that has been through these kinds of measures in this society or in societies like ours that will tell us precisely what's going to happen. So we'll have to model, we'll have to make our best judgments in public health terms, and then we'll have to try. And if things, if a measure that we take leads to more infection than we might have anticipated, we have to be really quick in picking that up and then addressing what it is we need to do to address that increase in infection. And one of the things that will bear on that, and really that we are going to have to give very careful consideration to in the nuanced public health advice that we'll have to give the public after the 5th of May, if we find ourselves in the situation of changing some of the arrangements that are currently in place, changing some of the restrictions that are operating, will be the effect of what you might call anticipatory behaviour. So as we went through the measures that were introduced to make the restrictions tougher, if I can put it that way, the public in many respects was ahead of us. So by the time we got to say it's time for people to cocoon, many of the people that we were talking about cocooning had already taken that measure. So they were ahead of us. What could happen in a situation where we begin to identify some measures to relax, that the message might get out in a sense that this is over, that we can take the foot off the gas. And that won't be the case. We will require a very strong set of measures on a continuing basis to keep this reproductive number at the level that we seem to now have it across society. And if that message gets out and we identify something that we think is appropriate to begin to reintroduce, and I won't predict what that might be, but if people interpret that as meaning we're on a pathway towards going back to the way things were in February or whatever, and people start to organise parties and concerts and get-togethers and so on, we will very quickly move back into a situation where that R number jumps right up and where we have cases, and as Philip's data has demonstrated to us, a jump in the R value to 2 could happen quite easily, and it could happen quickly. So within 3 weeks we could have a significant increase in the number of cases. Even an R value of an increase up to 1.2 would put us on an unsustainable track. We mightn't get there as quickly as we would if we jumped up to 2.4, but it would put us on an unsustainable track where we'd have to take measures to address that. So we really have to be absolutely confident, as much as we possibly can be, if we can contemplate lifting measures, that we'll be ready to pick up any infection that might result from those changes.
Okay.
Just to add, George, in building up that testing pathway, it has been very collaborative. Yes,
Yeah.
it's the HSE's job, but when we look back a few weeks ago, when we ran out of not just reagent but testing swabs, there was a cross-governmental, there were calls made from the highest level of government, and the HSE has been fully supported, not just by the department but by many different departments and ministers in trying to fix this. There's a job ahead of us, not just in making this testing pathway as lean as possible but the fastest possible turnaround time, but also addressing that issue of outbreaks in nursing homes to make sure we get rapid responsive testing so we can identify and quash outbreaks as they happen. But the work has been completely collaborative between yourselves and the department,
Okay.
for the record.
And just the very final thing, Dr. Hoolan, if I could just ask this, I know, is that we have so much spare capacity at the moment. It's so surprising. It's a good achievement. It's a function of success because we have increased the capacity in the health system and so on, and most particularly the reproduction rate is down so low. We have 2,000 spare hospital beds. We have 1,100 beds out in City West with just 71 people staying there at the moment, as far as I know. We have a lot of people potentially signed up for the health service. As you said yourself on one occasion, quite a few empty beds in wards. Have we too much capacity at the moment? I know if things go wrong, we'll definitely need it. But are we in a kind of situation where, a happy situation, where we have so much capacity we can breathe?
Can I bring you right back to where you started the question, if you don't mind, with Colm at the very beginning of your questions? And I'm not challenging the premise of the question that was based, but I do want to emphasise the point that the primary objective behind all of the efforts that we've had here is to protect people's health and to protect the health of the public. A secondary objective is to protect the health service. But the primary objective is to stop people getting sick in the first instance and picking up this infection because, as we've said, for a significant percentage of these people, particularly among the vulnerable, it has very serious and fatal potential consequences. And we know from the efforts that we've made and the figures that Philip gave you earlier on, and it's worth reiterating them, if we had continued on the path that we were on at around the time that we closed the schools, we would be reporting to you 7,800 cases, we think, today. We would be reporting to you that 800 people are in intensive care, not 150. We'd be reporting to you that in a week's time, 2,200 people would be in need of critical care. There's a good chance we wouldn't have been able to provide critical care to 2,200 people in 1 week's time. And we think by 1 week's time from now, we might have had something in the region of 1,500 to 2,000 deaths that we'd be reporting, and by the end of the month, have gotten up to something in the region of 5,000 deaths. And without suggesting that any one of us is complacent, we have averted that very significant impact. We have averted, if you like, the requirement, if you like, that led us to then have the health system prepared for, although our objective was to protect the health of people, if we didn't achieve that objective in the way that we have, we would have had a significant impact in the health system. That's why the work of the HSE had to be directed to increase the capacity, to make that available, both in terms of how the current stock was being used and the ability to surge that capacity to increase it if it was necessary. And those preparations have been put in place, and that capacity does exist. But we think now is the right time for us to start to think about measures, and that's why we've been advising the public around people who've been staying away from accident and emergency departments that shouldn't be staying away from the accident and emergency departments to attend, and to leave it up to the health service to figure out how to protect you from picking up this infection if you attend, and to, although the fear is understandable, to not let that fear get in the way of you attending either your doctor, to see your doctor, to contact your doctor, or to attend an emergency department if you feel that that's the appropriate action for you. Colm, sorry.
Just add, George, those surge plans, it's a relief to us and clearly to people who otherwise might have had to go into hospital, that we haven't had to lean into them so much, but they're every bit as relevant to us now. It's of course huge relief to us that the number of critical care admissions has stabilised so much over the past week, and that's a tribute not just to the measures that were brought in, but everybody in Ireland's compliance with those measures. Everybody, when we said then that everybody had a part to play in saving lives, we meant it, and we can see the fruits of that now. But you've seen from the modelling that when we negotiate our way out of this, we have to allow for the fact that measures will be reintroduced, or measures will be released a wee bit, and that we have to gauge the impact of those on the number of admissions. So we are not backing down on those surge plans, be they in ITU or be they acute beds. They're not going to be stood down. We need to keep them in place because for the future weeks or months, whatever is necessary on the basis of any change in case definition or any change in the social measures that were brought in.
Thanks, George.
I just have 3 questions, and feel free to be brief because I know a lot of our colleagues want to ask questions as well. We don't run out of time. Philip, can I just ask you, first of all, in case people missed the start of it or are trying to get a handle on this, is your modelling now suggesting that this is the famous peak that we hear about all around the world and people wondering when is it ever going to peak? Does your modelling suggest that this week is the peak?
The modelling suggests that we may have reached a plateau. The difficulty here is you're suppressing a disease when it's already at very low levels in the population, and your objective is to keep the number of cases low. But as a consequence of that, you're going to be seeing cases for a very long period of time if nothing else changes. So the notion of waiting for a peak is an understandable way to think about it, but a bad way to think about it, because you get a false sense of complacency, for instance. We're in a very delicate balance between suppression of the disease and potential future spike in the disease. So I'd prefer to think about it as it's under control, we think. It's in a plateau position.
Okay. And for people at home who are saying, you know, we've done a few weeks of what they would think is lockdown and we've a couple of weeks to go, does your modelling look at, why don't we just keep going with this past the 5th of May and see where we are then? What do you say to that? Where would we be if we kept doing what we're doing right now all the way into May?
And if nothing else happened, the disease would ultimately be suppressed on the island. But then what do you do? So at some point we do have to get to this discussion about how are we going to think about the restarting of economic and social and activity and things that are good for your mental health without losing control of the disease. So it doesn't seem to me to be a viable strategy to maintain this level of restriction forever with the hope of eliminating the disease, because then as soon as you do anything, the disease reappears. It just takes 2 or 3 people entering the country with the disease to restart it.
Okay, and final question from me, Tony. A lot of people are wondering, I've asked you this question before, should we be wearing masks in public? It was raised in the Dáil today that Taoiseach said that he'll defer to NPHET. We are seeing other countries changing their view on masks and other areas recommending that members of the public in public wear masks. Are you going to change your mind on members of the public wearing masks?
So the current advice that we have is in relation to the members of the public. We don't recommend masks for general use in the public. There are individuals among the public who will be advised by their doctors for particular reasons to wear a mask and to take particular precautions, and obviously we'd recommend that people follow that clinical advice. But unless you're told by your doctor at the moment, we don't recommend general use of masks in the population. That's the current position of the WHO. I've explained it before because it can lead to a false sense of complacency. People don't always use masks right. It de-emphasises the importance of other measures that are important in this particular disease, such as hand washing and social distancing. And for those reasons, the WHO currently don't recommend general use across whole populations. But we're keeping all this under review. All this evidence and advice is all subject to change at any point in time. And as part of the package of measures, if I can call it that we're thinking about in terms of post-5th of May, in other words, what kinds of things do we see happening after the 5th of May? Any and all of these things as part of our consideration. So it's conceivable, and I'm not making any prediction in this, it's conceivable that we might have certain measures around use of masks or PPE or other kinds of things as part of how do we learn to live in a situation whereby we're releasing some measures because we think it's important to do so, but we want to minimise the risk of transmission of infection having done that. And so any and all of these things are under the active consideration at the moment, which is not making any kind of prediction to you, but simply to say that we are open and responsive, if you like, to changes in both advice and evidence that's available to us as we consider all of those things.
And just very briefly, have you anything big that you're discussing at NEFIT tomorrow? As in anything, any changes being discussed? Is this just a review of where we are, or is there anything specific you're discussing?
So the main item on the agenda, Shane, is a constant review of where we're at. I don't anticipate big announcements, if that's what your question is asking me, but a lot of, let's say, preparation for the kinds of considerations that we need to be giving as we get closer to the 5th of May. An ongoing assessment of where we're at in terms of the preparation of testing and other arrangements. And we will be giving obvious consideration, as we do on a daily basis, to the current situation as it applies in nursing homes we detailed in the earlier part of the questions. But I'm not anticipating significant changes that we'll be making public, if you like, as a result of tomorrow's meeting. Thanks, Shane. Cheers.
Just in relation to the nursing homes and the residential settings, the last couple of days, the data from the HPSC has shown that the number of clusters, it had been around 10 for about 8 or 9 days, and it's gone down to 2 and 4 in the last couple of days. Despite all the bad news out of the nursing homes, is there any good news to be seen in that maybe the problem is being arrested to an extent?
Do you mind just giving me that data again?
Sorry, okay, so the number of clusters that the HPSC
Are you saying
has
the additional number of clusters? Is that what you mean? Sorry, yes, yeah.
Yeah, they're getting lower.
I don't think we'd be ready to be complacent, but yes, we have noted that the number of clusters, the extra number of clusters each day has gone down, yes. But there's still a substantial number there, and we still have a substantial challenge. So for this particular sector, and for community settings in general, obviously an increase in the number of settings in which the infection is identified, or an increase in the number of cases within the settings that have already been identified, are two ways in which the total number of cases can increase. I don't think it's time for us to be taking anything, let's say, encouraging as yet from the position that we've been reporting in relation to nursing homes. Colin?
Just to add to that, it might indicate a greater sense of awareness, as I mentioned earlier to one of your colleagues here, particularly in nursing homes among frailer older people. There's a very atypical or undifferentiated like presentation, and that may reflect the increase, the large number of cases at the outset. And now there's a very, when somebody becomes ill or goes off, there's a much higher index of suspicion among GPs, among geriatricians, among any other clinicians, nursing staff who are engaged with the care of older people. And so when somebody is ill now, there's a much greater awareness this may be COVID-19 than there might have been at the outset of this epidemic when it came to our shore. Yeah. And the nature of as I said, and it is important to emphasise this, the way that it can present in different ways among frailer older people, which are much more non-specific.
Are there any indications as to the voluntary take-up by HSE employees of going to nursing homes that are, say, struggling staff-wise because of people self-isolating? Or
I haven't got exact figures on you, except to refer back to my previous answer that we want to, rather than replace or dismantle or build again existing clinical governance structures, we want to build on the existing supports, whether they're GPs, nursing or otherwise, in a number of nursing homes. And working with HIQA, and it's important to acknowledge the work of HIQA, we've identified any nursing homes which are particularly at risk with outbreaks from the ones where we know where outbreaks have occurred. And in some cases, we've sent in staff and redeployed staff directly into the nursing home to support their staffing levels. But to emphasise again, what we want to do is build on their existing clinical supports rather than replace them.
Finally, for Philip, so the RNOT it's taken a fairly gargantuan effort on both the part of the state and the public to get it to where it is now. So how do we drive it even lower? Is it just a case of getting the testing right now, or what comes next? We don't necessarily need to drive it lower. If it's at 0.7, that's a manageable situation. So the objective is to keep it at or below 1. And that's the very delicate balance that Tony and colleagues are going to have to think through. In one sense, the measures that are in place right now are a very crude way of making sure you get it below 1, and that's simply to keep people apart with really extreme measures. The challenge over the coming weeks is how do you keep it at or just below 1 with more liberal measures, if I can put it that way, that allows some of the really important activities in society to resume. Okay, thanks very much.
Tony and Colm, just a quick question. Just to pick up on something you said, Colm, that in older patients it presents differently. There might not be a cough or a fever. This is something which other medical specialists have picked up on as well. They say that there may have been a significant underreporting of deaths, particularly in the early days of this outbreak here, where patients or residents in nursing homes might have been presumed to have died of pneumonia or other illnesses, and it may have in fact been unswabbed COVID-19. Do you believe that there is a chance that there may have been a significant number of unconfirmed COVID-19 deaths in nursing home settings?
What's impossible, we couldn't say we identified every single case of COVID-19 deaths. There's no way we could claim that. I wouldn't want to claim that. What I'm saying is, first of all, there's an emerging picture of a different kind of clinical presentation in older people, particularly those who are already frail. And that is, as I say, much more non-specific. Absence of fever, and people who deal with the nursing or medical care of older people will be aware that sometimes fever is absent, particularly even in severe infection. There's an absence of fever, cough or breathlessness. So some of those core features are just not there. In terms of unrecognised deaths, one of the pieces of work we're doing with NEFIT and through the HPSC is to track trends in mortality in nursing homes, as they would during a flu season, to see if there's any increase beyond what would be expected in numbers of death, and then link that to trends we're seeing from known proven cases and see if there's a parallel trend. So it is important to assure people in this country we are not just taking this seriously, but we're actively tracking and testing in nursing home settings. In other countries, the numbers aren't even included in their mortality data. So it's something we want to track, we want to trace, we want to detect outbreaks early, we want to provide care to the right public health leadership, we want to allow people to stay within the nursing home settings if they can, and transfer them, if that's clinically appropriate, to an acute hospital setting. That all those principles of care which underpin good clinical care of older people in residential care settings prevailed before COVID-19 ever came to our shores. The same principles apply now.
Certainly a possibility, though, isn't it? Is that what you're saying, though, that it may have?
Yes, it is of course possible.
If it is a possibility, we're going to detect it, because we have a number of different measures, and Colm has made some reference to this, and we'll be discussing this again tomorrow at the NEFIT. So what we've been reporting to you are lab-confirmed deaths. There is a possibility that deaths that occur that relate to this particular illness have occurred in people where a lab test hasn't been done. So we're seeking to broaden the case definition so that we catch more of those, if that's the case. We're also going to track, as Colm has said, the excess mortality, or to identify if there is in fact excess mortality in the population. I've described that previously to you, what happens in a normal, as it were, a usual flu season, where you have a low level of testing of patients, but you can see an increase in the total number of deaths over the course of a winter. That so-called excess mortality we want to be able to track. We haven't seen any change in that at this moment in time, but that's something that usually lags a period behind. I've written today to all the funeral directors in the country to raise with them the importance, with families even at this difficult and sensitive time, the importance of early registration and notification of these deaths to the General Register Office, so we can have early reporting, so that we have as much complete data as possible. There is a longer time available to people in this country than pertains in many countries for that process to be complete. And even though not everybody waits for the full 3 months, you have up to 3 months to do that in this country. We'd like to change those arrangements, but we've written to the funeral directors as a way of, if you like, trying to accelerate that, and not simply wait for the change in the legislation that we want to try and see to help to get that early reporting. And we're also going to be engaging in writing through the HPSC to clinicians to do two things. Again, raise with clinicians the importance of reporting and notifying deaths that could be related to this to both the public health authorities and to the coroners. And that doesn't always happen in as responsive a way as possible. And then to also raise with them the importance of testing of people who are unwell, and where the kind of clinical symptoms aren't necessarily those suspicious, to consider this particular infection, and to also consider testing of people who have died, as a way of greatly increasing our understanding of the impact of this. We think that's a range of measures which are very broad in terms of their application relative to measures that have been taken in many countries. And it's because we want to try and focus on where we now believe we have a challenge with this infection, as we've been doing in the last number of weeks, as we've made progress in terms of driving down the impact of this in the community and the spread of it in the community, which has to happen if we're to protect vulnerable people, whether they're in their homes or whether they're in institutions. We've focused substantially on on nursing homes, and we want to understand this pattern of mortality as well as we possibly can. That's why we're pursuing all of these different measures. Thanks, Richard.
I have a letter actually signed by Tony Holohan saying the pubs are going to stay closed till September. Fake news, I presume.
One of my children brought that to my attention today. I can absolutely assure you that is a fake, and I think you know that.
I'm wondering, could the number of cases of the virus and deaths as well in each care home and residential settings be published, seeing as that we're doing that for hospitals?
The number of
cases and deaths in individual care settings?
Well, some of those care settings are quite small, and I think we'd have to be very cautious about not identifying individuals. Yeah, but they're not as small as, I mean, some nursing homes are really quite small. I don't have a full spread of information available to me now about what the sizes are, but some of them are really quite small. And if we were identifying numbers of cases and numbers of deaths in individual institutions, I think we'd run the risk of identifying individual people, which we wouldn't want to do.
Okay, I take that as a no. I asked before about economic modelling, about the economic impacts, and I was given to understand, Professor Nolan, you're looking at that as well. Given the huge devastation being wreaked, sooner the better with this, surely.
So there's work happening, and we'll be engaging over the course of the period of time that we have now to the 5th of May with colleagues across government departments and with the Department of the Taoiseach on just those very questions, because as I've said on a number of occasions before, we want to understand if there are things that we would contemplate in terms of changes and measures, not only to identify those that have, if you like, the least possible public health impact, will make the lowest possible contribution to facilitating spread of the infection, those that have both the greatest economic and social benefit. And there is active work going on at the moment across government departments led by the Department of the Taoiseach, and we'll be doing that work over the course of the next fortnight.
Okay. I did ask before as well about issues around where residents of nursing homes get treated and whether they get transferred. And I was told that on clinical grounds they would be transferred possibly to hospital if that arose. But I wonder, are there any figures for the number of patients who've been transferred since this outbreak started from nursing homes to hospitals and even into ICU?
Paul, I don't have figures, but I know from talking directly to, as I said, in Portlaoise today, but to consultant colleagues and clinicians around the country, that they're able to tell me of transfers that have taken place. It's important to emphasise, and I know I'm saying again what I told you before, that COVID or not COVID, the practice remains the same. The best clinical judgment is used for each individual case. And for many people in nursing home settings, there are comorbidities such as advanced dementia or such as chronic illness, which means it's not the appropriate decision to either transfer them or to subject them to critical care. And for most people, if they have a life-threatening illness, the nursing homes would have experience in administering and giving that nursing and medical end-of-life care if it's appropriate. But for the record, there's no policy, there's no prohibition on the transfer, and there never has been, of the transfer of people from nursing home settings to care hospitals. None.
So, for example, in the badly affected unit in Portlaoise, where so many patients have died, of the remaining patients, have any of those been transferred to hospital?
Without going into detail, what I can tell you was they got a type of treatment and assessment which was better than acute hospital care, in that the consultants from the hospital up the road came down to the hospital. They went through each case over the bank holiday weekend, Saturday, Sunday and Monday, and were actively involved in directing the care in conjunction with the nursing and medical staff in the mental health facility, and that included administering specialist end-of-life care where appropriate.
So none of them were transferred to hospital?
Each case, as would be the case in COVID or not COVID, was judged on its clinical merits and judged on what was clinically appropriate for the patient. And it was their judgment that the care of the patient was best delivered in the setting where they were, namely St. Vincent's Hospital.
Okay, it's just that the word, when you talk to people who've been interacting with individual nursing homes, the line they're getting is that your family member won't be transferred to hospital. There might be some message lost in translation or something, but it's a fairly blunt message that people keep hearing it.
I can't control the error.
But in this case, we find that even though we hear from local people there, many of those other people, other residents of the location in Portlaoise are positive. None of them have been transferred to hospital.
I think it's important to focus on the care, not where the care is given. Okay. And the care in the case we're talking about now had the direct involvement of consultant staff from Portlaoise General Hospital. On a daily basis over a bank holiday weekend, not just for the cases that we're talking about who tragically died, but also for any other cases of positive patients. There was on-site clinical care and direction in conjunction with the team who knew them well, best, and sometimes for many, many years, where the residents had been living there with chronic conditions. Could I say, take the opportunity that having seen what they did and how they worked with the public health lead, Abby Collins, it was an exemplar of cooperation between clinical staff and public health and how something could be managed in an outbreak setting.
And finally, I asked last night about whether nursing homes were told not to discuss outbreaks with families of residents. And Tony, you said that there was no instruction not to brief families about outbreaks. I just asked Nursing Home Ireland about the situation, and they said to me that they were informed by NPHET that patient confidentiality in all cases should be respected, and it would be the Department of Health would provide updated information as necessary. And according to Nursing Home Ireland, they told me that that they were informed, that nursing homes were informed that the department and the HSE were the lead in disclosing information regarding COVID-19, and the homes were instructed in this regard. Does that not amount to what I was asking about yesterday, basically that the information was being controlled by the department, and nursing homes saw fit from the information they were given that their direction was not to discuss these issues with families?
No. I mean, so a statement from here about the importance of protecting patient confidentiality in all circumstances is something that we would articulate at any moment and would confirm and continue to confirm as an appropriate standard of medical care to be able to offer to the whole population. And any interpretation that that's suppression or an instruction to people to not share individuals' information with individuals would not be correct. So
would that include talking about the size, the number of people affected in a home, the size of an outbreak, for example?
So all we would have said, and I haven't seen that particular correspondence that you're referring to there. I haven't seen it personally. I'm not doubting it, but I haven't seen it. So all we would have said is to talk about, and I will continue to do this, the importance of protecting privacy and confidentiality in the delivery of any health service or any social service that we provide, and that either we as the department, the HSE as the delivery or funder of healthcare, or the individual providers all have an absolute obligation to protect those principles. Those are basic ethical principles that we need to be able to uphold and to assure the public we continue to uphold, and we've talked about them on many occasions here. That's as far as we would have said. No such instruction was issued beyond that to anybody, to bind anybody in any way other than the ethical principle of patient confidentiality and privacy, and we continue to strongly uphold those. Thanks, Paul.
Ronan Duffy from the Journal.ie. Just a quick one on testing, Tony. I think you had talked about the case definition earlier on this evening. I think you've said you expect it to be changed next week. Is it a given that it will, when it's changed, it will return to what it was when it was previously expanded?
No, it's not, and there are no givens, including the fact that it might change. That's not a given. It's conditional on all of the different things happening. So I was just giving you a sense of the things that will need to happen before the 5th of May if we're to find ourselves in a situation at that point where we think we can recommend a change in the current arrangements.
I think it was based on Simon Harris said today he expected it to change next week as well.
Yeah, so those would be the appropriate timelines, but obviously it will depend on, first of all, the disease and all the characteristics we've talked about and that Philip has outlined to you earlier on, that we track around the behaviour of the disease, that first of all is giving us assurance that this is the right thing for us to do, and that second of all, that all the preparatory arrangements that need to be in place from the initial point of a person attending a GP or consulting with a GP, through to sampling capacity to take a test, through to testing capacity to process that in a lab, through to the referral of that information back to the individual through their clinician, through that individual being the subject then of contact tracing, and for that contact tracing to be active in its follow-up, and for those contacts to have testing as well, and for all of that to be supported by a dynamic real-time information system, and all of those steps happening in line with the up-to-date and new evidence and guidance provided by the WHO. All of those requirements have to be satisfied to allow us to contemplate changing the measures on the 5th of May. And so it's in that context that a possible change in case definition would arise next week. But there's no givens about either that will happen at that time, or indeed that it will be a particular case definition that will apply. But what our intention now would be to be optimistic. If we do find ourselves in a situation of being able to lift restrictions on the 5th of May, it will be because we've been able to work with the case definition, which is more sensitive or broader, helping us to greatly increase the chance of picking up a case were it to occur after the 5th of May as possible. That would be the intention. Thanks.
Rob O'Hanrahan, Geo.ie.
Right.
My question is simply around the modelling that was provided this evening. Will that be published in a manner that will be greatly or easier for access for the public? So is it going to be published online, or will there be any way that the public can access that information readily?
So, so the slides that we've shared with you this evening, I noticed a number of you were taking photographs of them and so on. So that information, which is the output of the modelling, that's what we'll make available.
And that will be made available, online for the general public?
Yeah.
Or?
Yeah.
Yeah, perfect. That's great. Thank you.
Yeah. Thanks. Thanks, everyone.